everyone, and many thanks for joining. As you know that we have the webinar on a very important topic, that is on forgetfulness and dementia, aspects of frailty, and about falls and fractures in elderly diabetics. I think these are something which we all know. And while I wait for Dr. Akash Singh, who will be chairing, uh, I would like to just say that this is an important topic, and I think everybody has come across or does come across with these problems whenever they deal with elderly patients, particularly when they deal with diabetic patients. And I'm very glad that our faculty has agreed to contribute their contribution in this webinar. So I think without any ado, we can start. In the meantime, as Dr. Akash Singh joins, he can then start conducting the proceeding. And he would, as I told him before, he would be calling one by one the esteemed faculty members, and the discussion will be towards the end for about 15 minutes. So I think I would just first like to invite Dr. Anand P. Ambali. He is professor of geriatric medicine, a highly academic person, has lots of contributions in particularly in various facets of elderly medicine, and he very kindly agreed to take up the topic of dementia, including forgetfulness in elderly diabetic. And without further any spending time, I would request Dr. Ambali, the floor is yours.
Thank you so much, sir, for this. Thank you so much, sir, for your introduction and your invitation for me. I am extremely privileged to be amongst you all, and of course of other esteemed faculty members today evening. So greetings to you all from Geriatric Clinic of Sri B.M. Patil Medical College. Am I audible, sir?
Yes, you are.
Slides are seen. Yes. Pratap sir, slides are seen, sir.
Are my slides? Yes, audible as well as visible. You can go
Thank
ahead.
you, sir. Thank you so much. So we started our geriatric clinic way back in 2007, and now we are having 2 MD geriatric medicine seats from 2021 in the field of geriatric medicine. And apart from that, we also have a rural health scheme, immunization clinic, dementia clinic as well in our geriatric clinic. So with this background and taking the permission of chair and moderator, sir, I now discuss a few things about diabetes and dementia or forgetfulness, as Rasa rightly mentioned. So looking at the next 14 minutes, so I'll be discussing how the diabetes leads to dementia and what are the identification signs, what's the role of caregiver in this, and how to notice the behavioral changes and find the solutions for that with the take-home messages. So we all aware that diabetes is we are becoming capital of a world. So 1 million, that's the latest numbers, and so is the aging population is increasing. 149 million people in India. So diabetes per se leading to impaired cognition is on rise in older population, and this impact gives a negative impact on the quality of life of the older people. And over a period of time, once they develop full-blown dementia, their dependency level increases on the caregivers, and they develop a poor quality of life. So as far as treating diabetes is also concerned, now most of the studies have come showing some effect of some medicines, especially oral hypoglycemic drugs. They are more beneficial in preventing or delaying forgetfulness or dementia in patients with diabetes, while some drugs are known for that, which we'll discuss. And of course, any patient with diabetes now, we can delay or prevent the complication, especially the forgetfulness, as we are giving importance to the cardiac events and renal events and related to ophthalmic events. So this event should not be ignored, and that's why I think Professor Vinod sir has brought this very important topic regarding prevention of forgetfulness and how that leads to other complications in diabetes. And the most important person in treating the patients with diabetes is their family member or a caregiver, what we call, and by default, we all are caregivers for our grandparents. Now, looking at the prevalence of diabetes from the last study, which was published, I think Sir was also part of this. So, what is important here is the self-reported diagnosis of diabetes among the older people is between 60 to 74 is 14.9, and more than 75 is 11. So, almost 26% of the older people among the study group are having diabetes, and most of them are in the urban areas. Now we cannot ignore this 45 to 59 people over 9 to 9.2%, because shortly they will add to the 60 to 74 range, and the longer the duration. Suppose today middle-aged man at 45 develops diabetes. At the age of 65, he is likely to develop dementia, or at the 70. So they are all the challenges in coming years. Though we cannot ignore any of these people developing diabetes at the young age, they are going to be challenge for the physician in a few decades. So the challenge, another challenge in older persons is people above 80 years. The number of people who are living 80 years and above is increasing, and they will be not only having diabetes or all non-communicable diseases, but their complications and requiring rehabilitation and palliative care. So in that, again, if they develop dementia or forgetfulness, a huge challenge for the family and the consultants. So diabetes leads to dementia, further depressions, dyslipidemia, diabetes, end organ damage, and disability. A lot of importance has been given to all the Ds, from depression to disability, but not much was talked about dementia. So we will explore how it can be assessed and what can be done in the coming years. So coming to the new concept of this optimizing brain health by WHO, they say that brain functioning across cognitive, sensory, socioeconomical, behavioral domains, allowing a person to realize their full potential of life course, irrespective of presence or absence of disorders. So that is where we as a physician strive hard. So optimizing brain health is very important because it is also an end organ. So improves mental and physical health. So creates a positive social and economic impacts, and that contributes to the overall well-being and a good quality of life among the elderly people. Now, this concept that has been brought by WHO says that looking at the age, neuroplasticity starts at the young age and diminishes as we grow old, and pruning takes place in between and it disappears. While this is very important, the midlife neuronal loss starts and proceeds with the older age, and this is where most of the non-communicable diseases take part, and even other habits also take part in this course, and they lead to dementia or forgetfulness in the older people. Even the Lancet, when it brought the risk factors for cognitive impairment, is a very beautiful picture showing what are the risk factors at each age group. So in the late life, the diabetes is one of the risk factor for developing dementia in the older people. Though it constitutes only 1%, two things are very important in this. It is mostly preventable. Mostly the progress to dementia is preventable, and if it just 1% is maybe it looks small here, but looking at the number of older people in India and people with diabetes in India, definitely this accounts to the larger number. So how diabetes leads to dementia? So diabetes per se can lead to dementia. The medicines that we use in treatment can lead to dementia. The complications of diabetes, especially hypoglycemia, can lead, and of course genetic involvement, which is we cannot divert or prevent those things. Now, looking at the dementia, whether occurs in type 1 or type 2 diabetes, most of the older people have type 2 diabetes, but we do still see type 1 in the older people. But in type 1 diabetes, the most of the slowing of mental speed takes place, and memory and learning is not affected. While in type 2, psychomotor speed, executing the functioning, and memory are largely affected over a period of time. So type people at type 2 are definitely prone for dementia. Now you look for why it is produced. A lot of factors in type 2 diabetes which leads to cognitive impairment like HbA1c. The larger the HbA1c, the the brain volume starts coming down. Resistance to insulin and hyperinsulinemia. Hypo and hyperglycemia are extensively studied, known to produce dementia. Hypertension, genetic depression, and most importantly, peripheral artery disease. If the person is with diabetes having peripheral artery disease, definitely he is bound to develop dementia as well. Now, coming to neuroplasticity, the main center for all these activities for neuroplasticity is the hippocampus, where there is a reduced neurogenesis due to diabetes, and this neurogenesis and the hippocampus impacts on the learning and the memory of the older people, and that is how the neuroplasticity doesn't work as we grow old. But can we measure neuroplasticity? No, we cannot measure neuroplasticity in live patients. If only postmortem helps to understand the hippocampal neurogenesis, whether it's taking place or not. Now, coming back to the pathophysiology, the mechanism through which hyperglycemia affects the cognitive function, it depends whether it is acute or chronic. So basically two things sets in. One is vascular pathology and second is degenerative pathology. Both combined together works in the pathogenesis of dementia in patients with diabetes. So acute hyperglycemia leads to a reduction in cerebral blood flow that results in changes in oxidative stress, and this leads to large number of reactive oxygen species, which leads to oxidation insults. And when the reactive oxygen species exceeds the antioxidant response, the neural damage occurs with subsequent functional decline. This is how pathogenesis occurs in acute stage. While in chronic hyperglycemia, there is accumulation of advanced glycation products, and this exacerbated, leading to the formation of ROS and pro-inflammatory cytokines, which again leads to microvascular damages in the brain. And not only that, it also, the advanced glycation products accelerate amyloid beta depositions and plaque formations, which further makes the elderly prone for Alzheimer's disease. Now, coming to hypoglycemia, a lot of studies have been done on the huge numbers of patients. Even one study shows to almost lakhs of patients were revealed hypoglycemia associated dementia with the odds ratio of 1.5. And another study published in Diabetes Met, 53,000, revealed 26% increased episode of dementia development with one episode of hypoglycemia, while 50% increase in those who have multiple or recurrent hypoglycemia. So hypoglycemia leading to cognitive decline is very, very important thing that we are dealing with. We almost every week, every month, we get one or two older patients coming with hypoglycemia. So that is how the impact is taking place. This is the another study which tells you where is the duration of diabetes anything to do with the dementia. Yes, the number of years as we pass, the risk for developing dementia is more. In this study, it was very clear that up to the 5 years of diabetes, very less people were there. And as the duration of diabetes increases, the more number of people develop dementia. So earlier, that's what I told you, that the people in between 45 to 60 now, when they develop diabetes, at the age of 70, when they come, they will be having dementia. Now, can we take this as type 2 diabetes, Alzheimer's disease? For all of us here, all of you are known that, but the audience here should know that it is still an unofficial to mention Alzheimer's to be a type 3 diabetes. But why the concept came? Because insulin plays a critical role in formation of amyloid plaques and phosphorylation of tau, which leads to neurofibril tangles. So insulin resistance leading to type 2 diabetes, and insulin is a brain leading to plaque formation. That is the probable pathogenesis that has been described. So some authors mentioned it as type 2 diabetes, but it is still not an official thing. Now, coming to the concept of which medicines that we use to treat diabetes can lead to cognition impairment or cognition improvement. So this is a study of one of the meta-analysis from 22 studies using 7 medicines from DPP-4, sulfonylureas, metformin, insulin, pioglitazone, and this darker thick lines tells that more number of studies have been done on these medicines, and what they found over a period of time is the medicines that are protective, oral hypoglycemic drugs that are protective are metformin, pioglitazone, and sitagliptin. They have found to improve and or delay the memory loss or dementia, while insulin is known to produce memory loss or dementia. Now, coming to knowing all this pathophysiology and all, then when to screen. When the old person comes with a history or usually from the family members that he is not able to take care of himself, okay, and without obvious reason, then suspect that some cognition impairment is there, and evidence of end organ damage like stroke or cardiac events that can even further lead to dementia, and duration of diabetes, as I've been emphasizing, history from family members of red flag sign. The old man is forgetting, some old lady forgets to off the gas stove in the home, or they misplace the things, or they wander. So many red flag signs are there, and if that comes, history is there, then we should definitely enter into the deeper examination. And all older people above 70 years with 70 years with diabetes, not of with diabetes, should undergo a screening at least once in a year. Though there are no clear-cut guidelines, but a lot of studies are telling that go for screening for dementia as we screen for albuminuria. And history of hypoglycemic episode definitely makes the older person risk for dementia. So these are the various screening tools that we use in our geriatric medicine, MMSC, MOCA. We in our clinic, we use MOCA. We are very comfortable with that. Some authors, they do Edenbrooks, and some are comfortable with MMSC. Any one of this can be used. Now coming to the last aspect, what is the impact? So knowing that diabetes is there, yes, how it happens, yes, and how dementia is going to be there, how it affects the older person. So they,
Dr. Ambani, can you wind up in next 2-3 minutes, please?
Yes, sir. Yes, sir. So what are the impacts? So difficulty recognizing the symptoms of hypoglycemia in the older person is a very negative impact on the patient's quality of life, and complications are least described or identified. So if the older person is forget to monitor glucose, then decrease frequency, give the pill box or alarms to ensure that he takes medicines. And if the patient is having problem solving difficulty, so repeated education and repeated visits has to be done. If the patient is adamant that I don't want to change and he is stubborn, refuses for new therapy, as much as possible try to avoid and don't add new things for them. And difficulty with mental flexibility, they feel anxious or regarding failing the treatment plans. So simplify regimes as much as possible and avoid insulins if it is possible in this older people. Now, the most important person I told, caregiver training. We need to train the caregiver regarding identification of red flag signs in them. Insulin dosage has to be monitored. Symptoms of hypoglycemia should be taught to them that we do, as a physician, we do that. Identification of behavior changes and pill reminder should be done. So exercise does prevents occurrence or delaying the dementia in older people by ways it improves the neuroplasticity, working memory, cognition, and those. Even WHO is giving a lot of importance for dementia risk reduction, and that is what we are doing through this program. So the take-home message is there is an multi-domain intervention in people with dementia and diabetes, because the diabetes itself is not a single entity nor the dementia. It is multiple components, and multiple team has to be worked. As much as possible, we have to avoid stringent control by AIC and avoid insulin as much as possible unless it is indicated, so that hypoglycemia should not develop. Screening for cognition should be regular in all the older people, at least those who are 70 and above. Caregiver involvement is of paramount importance. And to retain sweet memory, prevention is a key. And of course, the dementia and diabetes can, as a complication, leads to falls, fractures, and frailty, which will be discussed in detail by our next extreme speakers. So with this, I conclude and wish you all a very happy Sankranti to you all. And these are my references. And thank you for your patience.
Thank you, Dr. Ambali, for in a limited time you have touched many aspects. I was particularly impressed about the impact of dementia on diabetes with regard to the behavior and all sorts of complications, falling down, getting fractured, if you do not know about dementia in this patient. So I think very important message has been given. And now I think I would like to welcome Dr. Akash Singh, who is actually the chairperson of this webinar, and he would be calling the speaker, inviting them one by one. And as I said in the beginning, the discussion will take place in the end for about 15 minutes. May I first introduce Dr. Akash Singh, our chairperson. Dr. Akash Singh is a senior consultant in medicine and diabetology in the city of Vadodara, and he is also the president of Indian Association of Diabetes and Cardiometabolic Diseases Association, and he has many awards and many publications to his credit. He's very active in the RSSDI and API. And with this, I would invite Dr. Akash Singh to kindly take over and invite the next speaker. Thank you.
Thank you very much, Dr. Vinodkar. I'm sorry to join late. I will just like to have the slide of Dr. Robashi also for the next lecture. The introductory slide of Dr. Anubhav Srivastava. She'll be, Dr. Anubhav Srivastava is MBS, MD Medicine, MSc in Neurology, and has several fellowships to her credit, several gold medal certificates, and she is a coach in the ACP Wellness Program, and there also she has won an award. So there are a host of awards which have been awarded to her, and she has been a very, very regular speaker in all the national conferences in medicine, diabetes, and neurology, and also a judge for the poster presentation sessions and all. So basically, she is a very, very acclaimed speaker, and I would like to invite her to speak on the next topic, which is allotted to her. Dr. Aruma Srivastava.
Thank you, Dr. Akash, for a kind introduction. I would like to thank Vinod sir, Pratap sir, for giving me this important session on frailty. I'll be sharing my slide, and I'll go through an important topic when we talk on diseases governing the challenges what elderlies actually face. So I'll be talking on frailty in elderly diabetes. As my previous speakers has very well mentioned about the increasing prevalence of the elderly population because of the advances in public health and modern medicine, which is globally, and in India also the prevalence is high. So we have different issues, unique challenges, especially in the older diabetic individual, which were traditionally not seen. So these challenges are medical, psychological, and functional issues, a myriad of problems, among which the previous speaker has talked about the dementia and depression, definitely. So these individuals, the elderly individuals, have two or more simultaneous long-term health conditions, which is in Indian subcontinent, around about 32.1% of older people have a multi-morbidity associated with them. So frailty, to define, it is a progressive loss of reserve and adaptive capacity associated with overall deterioration in health. If you see, the prevalence of a pre-frailty is much more common than actual frailty. And if we diagnose, if we routinely start screening our population, definitely we can make a change. As you can see, this stage can very well be reversed to robustness. It's a condition where there is reduced muscle strength, unintentional weight loss, loss of low energy expenditure, slow walking speed, and exhaustion. I think most of the diabetic in a slightly elderly age group, 65, 70, may have these symptoms, which if we do not question, we may lack to identify a pre-fail individual, and hence we will land up in in disability and dependency. So we are actually facing twin epidemics of frailty and diabetes. Of frailty, which is the loss of biological reserves of across the multiple organ system. So why we talk about diabetes and frailty? Because frailty is 3 to 5 fold higher among diabetics and is the single biggest factor of mortality. Frailty is a common finding. If we see in elderly population of 65 years, it ranges around 32 to 48%. And the frail older people with diabetes may suffer from malnutrition or sarcopenia. So the various risk factors which are already there on the background of inflammation may causes physiological organ changes and may produce signs of weakness, weight loss, exhaustion, low activity and slowed performance. And this may not be associated, they may have certain signs of dementia or Parkinsonism, but frailty is independent of this diagnosis, and hence the problems of falls, disability, dependency may be higher. So there is a shared pathophysiology between frailty and diabetes. The oxidative stress, the chronic inflammation, the sarcopenia, they all may result in, once the frail patient may have an independent risk factor for morbidity and mortality in diabetics, and vice versa, the diabetic patient may have worsened complication and malnutrition in diabetes. So if we see a patient, if we follow from robustness, where he's able to do all his routine activities independently, to the exhaustion stage, and if they lands up into, if the progression is more, they may lead into disability. The metabolic syndrome, along with chronic inflammation, may produce a symptom of sarcopenia, loss of muscle mass, loss of strength, loss of speed, and leading to weight loss, along with nutritional deficits and anemia. So there is a cascade of oxidative stress, aging, and inflammation, producing a multi-system dysfunction and frailty. That was about the pathophysiology. We are very well aware about the chronic inflammatory condition and the uncontrolled diabetes deteriorating the situation. So why talking about frailty is important in diabetes? You see, catching the patient in a the pre-frail condition is very important. What are the higher risk of individual? The elderly patient, the female group, the patients who have not been better controlled, high BMI, high waist circumference, inactive, smokers may other one may have more going towards frailty. And diabetes is associated with accelerated aging process that promotes frailty. So the complications, especially renal impairment and dementia, may definitely pave the way for frailty. So the screening and assessment is very, very important. Detecting frailty in older people with diabetes is important to target intervention to reduce the functional decline and risk of debility. The various key assessment factors could include the physical performance, which we'll be talking about, mental health and cognition, which Dr. just talked about, and definitely the nutrition. So early identification of pre-frailty is a potentially reversible condition. Some of the tools like the scoring index, the simple get up and go test, the Prisma tool, the sarcopenia, they can be helpful. Simply, if we can ask one of the patient to get up from the chair, to walk around a 3 meter and sit back. If he's able to complete for 10 seconds, he is still active and they don't show any, they are robust. Another is a 4-meter walk test. If the individual is able to complete within 5 minutes, so he is having robustness. So there is one of the criteria, the presence of the 3 or more criteria, like difficulty in mobility, that is slow gait speed, muscle weakness, the hand grip weakness, decreased physical activities and poor exercise tolerance, exhaustion, which is self-reported, and unintentional weight loss. Just if we can ask 5 questions to a patient and assess at the routine checkup, the presence of 3 or more may suggest a frailty, 2 or more may describe a pre-frail state, and any of this absence may tell you about the robustness. So this frailty assessment in diabetes can be done for the patient-related symptoms at any visits where this questionnaire or the questions can be asked. The 4-meet gait speed test or a get up and go test can be there, or a questionnaire can be used, and we can go for the testing about the neurological complication, the nephrological combination, and assessment can be done. These are the questionnaire which I was talking about. 7 questions, 3 out of 7 may show that the patient is suffering from. This is a clinical frailty score, and obviously this can help us to give an idea about this patient may have symptoms of frailty. There is an overlap between sarcopenia, where there is a skeletal muscle loss, and poor muscle quality, which is just an overlap to a bigger spectrum of weakness, slowness, physical functional impairment, fatigue, deficits, weight loss. And there are lots of interrelated things which are resulting into it. The complications, the comorbidities, the inadequate nutritional intake, the low physical activity. For the sarcopenia, this is one of the European Working Group guidelines on older people. Any individual, we can measure the gait speed, to measure the grip strength, and assess for the muscle mass, and can diagnose sarcopenia, which is a entity seen in the elderly age group. And polypharmacy is one of the associated features with frailty and multimorbidity, the principal causes of polypharmacy. And early detection of frailty, right choosing of medication, simplification of their treatment chart may be helpful in a long way. So we have talked about what is frailty, what are the pathogenesis, and now what can be done. So what are the target setting and the recommended intervention? So we can divide it into pre-frail individual, a moderate level of frailty, and a severe frailty. A pre-frail individual, the target should be reversal of frailty with a tight glycemic control and enhancement of resistance exercises and nutritional interventions. And the moderate, a glycemic control should be modest of less than 8. Assessment of cognitive decline should also be there in the checkups. The aim remains for the prevention of decline in the quality of life and prevention of microvascular complication. In the severe frailty, go for the modest prevention of hypoglycemia seems number one in aim, with the control of A1C less than 8.5 and prevention and making them slightly independent. This is the standard of care, diabetes care 2022, of the goals of the treatment, and a modest level of blood glucose and blood pressure as the frailty level advances. So the mainstay of the treatment as of the diabetes specific in this population also is nutritional management, which is high calorie, high protein diet, and which has shown, especially in heart failure patient, to improve the quality of life, and 6-minute walk test. The micronutrient deficiencies, especially seen in frailty, include vitamin D, E, A, and B12. Thiamine, iron, folate should also be suggested. So a holistic checkups or workup can be helpful in assessment of comorbidities, the nutritional status of the individual. So there have been various studies which have shown if we diagnose the patient in the pre-frail stage, the reduction in the frailty can be achieved with a structured exercise intervention, and the various studies have shown to it. So the various types of exercises, the intensity, the flexibility, they can be advised according to the stage of the disease. Now comes to the pharmacotherapy. After the diet, the exercise, this can also be evaluated in the 3 stages: the mild frailty, the moderate, and the severe, according to the comorbid condition like the heart failure condition, atherosclerotic heart disease, or the kidney disease. The choice of the drug of metformin, DPP4 seems to be a safer drug with less chances of hypoglycemia and any complication. But if the atherosclerotic heart disease factors are present, the role of SGLT2 and GLP-1 may be good enough. If the A1C is controlled, If the patient is on insulin, the basal insulin and the dose reduction should be there. The avoidance of pioglitazone in heart failure patient, and if the renal function deteriorates lesser than 30, the choice of the drugs becomes linagliptin or the insulin as per the age. The moderately failed patient, similar, we have to maintain around 8 HbA1c with the choice of the drug according to the dependent upon the complications as well as the stage of the disease. Hypoglycemia should be prevented, and sulfonylurea should be reduced or discontinued as and when required. Choose a slower dose of insulin, a longer acting insulin may be helpful. In severely frail individual, at any HbA1c, discontinue sulfonylurea, discontinue thiazolidines, and stopping metformin and GLP because there is sarcopenia associated with it. So insulin may be a long-acting, can be a good choice. If there is no features of heart failure, DPP-4 also seems to be a good choice. So this is one of our study which is done at our center where we have assessment of sarcopenia in type 2 diabetes, and we are using CT based assessment of muscle mass and its association with complication. Around 100 patients, we found around 37 patients having sarcopenia, and out of this we had around 20% in elderlies. So it is not so uncommon. To summarize my talk, when talking about the therapeutics, start low and go slow. So the escalation and the dis-escalation of the medications are very important in frail older individuals, and they need to be assessed regularly. The focus on random blood glucose should be at 120 to 200 milligram per day instead of A1C targets. Hypoglycemia should be prevented. Assessment of frailty should be routine component of diabetes review for all older individuals. Glycemic targets and therapeutic choices should be modified accordingly. And we have to eliminate both hyperglycemia and hypoglycemia. So this is one of the association of the British Society where the assessment, the care, and the management should follow as such. Just to conclude, frailty rather than age determine the prognosis of older adults with diabetes, and therefore a key determinant of target setting and treatment choices when individualizing care. So the glycemic treatment targets and de-escalation thresholds are generally accepted, though they are not formal guidelines, but definitely there are certain do's and don'ts, and we should follow that. Thanking you and happy Makar Sankranti to everyone from Prayagraj.
Yes. Dr. Akash Singh.
Thank you very much, Dr. Ruha. That was a very lucid and very crisp lecture. It is challenging for the healthcare providers to identify and address the epidemic of diabetes, dementia, and frailty in the aging diabetic population in India, which has genetic and acquired factors in background. And this increases the vulnerability of this population to increased falls and fractures. And to talk on this interesting topic is none other than the illustrious speaker, Dr. Sanjeeva Reddy, who needs no introduction. But if I can have the introductory slide, I would like to introduce him. He'll be talking on this subject. Dr. Sanjeeva Reddy is consultant diabetologist at Center for Diabetes Endocrine Care and Fortis Hospitals, Bangalore. And his short introduction speaks for his immense humility. He is one of the tallest figures in diabetology. I will request him to proceed with his lecture.
Thank you, Dr. Akash. Thank you very much. Thank you for those nice words. Give me a minute before I share my slides. Hope it's visible. Sir, am I visible and audible?
Yes, you are.
Yeah, thank you very much. At the outset, I would like to thank Dr. Vinod Kumar and Dr. Pratap for asking me to talk on falls in the elderly with diabetes, risk factors, prevention and management in the next 15 minutes. Pardon me or stop me if I'm taking if I overshoot my time, and I thank the two speakers for setting the target on diabetes and dementia and frailty. I think frailty should be the one to assess somebody who's elderly or not, according to me, but we'll take up that in the discussion. Now, this is what, just looking at fall when you are normal, when you're not too elderly versus as you grow frail or where you grow elderly, how you fall. Just a picture predicting it. And what does epidemiology of the falls in the elderly say? After this, I'm going to talk about diabetes and falls, and then how do we prevent them? So the easiest one is unintentionally coming to rest on the ground floor or other lower level from another position because of no major intrinsic activity. These are all definitions of a fall, and we've all experienced this in our families. And what are the different types of falls? So we may have falls which can be triggered by intrinsic or extrinsic factors. As a consequence of the fall, you can have injury, may not have major injury. They could be fallers, first non-fallers at all, but they can be once only fallers or recurrent fallers. So whatever the consequence of the fall is always not good in the elderly. Let's look at what happens. Accidents are the fifth leading cause of death in older adults. Forget about cancers now. We're looking at all the infectious, non-infectious disease, malignancy, and the cardiovascular disease, and the fifth largest cause for death in older adults account to 2/3 of these accidental deaths. 1/3 of adults over 65 in the community fall at least once a year. And we're looking at Dr. Sivatsa's slide on how many people are going to become more than 60 over a period of another 20 years in our country. I think the ratio is going to be reversed from the age of 30 and 60, and we can imagine how many falls we will have. The raise of this raises up to 50%. Half of the adults over the age of 30, over the age of 80, tend to fall, and 5% of them result in a fracture or hospitalization. The morbidity abnormalities affect 20 to 40% of adults over 65 and 40 to 50% of adults over the age of 85. Mortality of those who are hospitalized, 50% will not be alive a year later. This is more dangerous than cancer. You have a major fall and if you're hospitalized. Falls constitute 2/3 of death associated with unintentional injuries. In 2000, traumatic brain injury accounted for 46% of the fatal falls. And the costs related to the fall, I'm looking at figures in 2000, between 24, you need not, this can be like billions of dollars, which it is around $19 billion. I don't know, you can't quantify the loss in terms of money alone, in terms of what the family goes through, how much money the government incurs, expenditure, direct and indirect cost can be enormous. So epidemiology of falls in the elderly, where do falls occur mainly? Are they indoors, outdoors? Most falls occur outdoors. Women are likely to report more indoor falls. Indoor falls are associated with frailty. We just had a talk on frailty, and we see that people who are frail have more indoor falls. Outdoor falls, because when you're frail, you're not going outside more. So there's a reason for indoor falls and frailty. Outdoor falls are associated with compromised health status in more of the active elderly. Now, the rate of falls and their associated complications are twice over the age of 75. 10 to 25 falls induce fractures in this population. Now, do all falls cause fracture? No, 10 to 25% of them over 75 years of age. This is not data from the diabetic. I will present that too. Hip fractures are the most common after the age of 75. Those greater than 75 years of age are more likely to report indoor falls. Incidence of these are higher in institutional elderly, diabetes, Parkinson's disease, post-stroke, patients with neurological disease or disorders. Now, one of the largest study till date looking at the risk of hip fracture and non-skeletal fall injuries in the elderly. This was the Frailco study. This was a Swedish study done from the Swedish registry, had more than 429,000 patients aged 80. They looked at 80.8 plus or minus 8.2 years from the Swedish registry or the senior alert and linked the data to several nationwide registry. They identified 79,000 individuals with type 1 and type 2 diabetes, out of which 41 were on oral medications, 14 were on 14% with no anti-diabetic medication, and 45% with insulin. Now, let's look at the data. What did the conclusion of this? They looked at various factors. They looked at comorbidities. They looked at the association, whether what happens with type 2 diabetes and these. And what the conclusion of the study was, it did lack a lot of data on HbA1c level. It did lack data on smoking. There were certain factors missing in terms of activity level, cognitive factors. But the conclusion of the study was patients with insulin-treated type 2 diabetes should indeed be considered as a high risk for future fractures. But all patients with diabetes and any kind of anti-diabetic pharmacological treatment having as an increased risk for non-skeletal fall injuries and may benefit from primary intervention strategy, primarily aiming at reducing the risk of fall. So any diabetic, for that matter, more so people with insulin who are on insulin are more prone for fractures. And what they found was people on insulin had more rib fractures, and other non-skeletal factors were more on people with OHS. So this is in duration of diabetes, there was not, and the longer the duration, they had an increased risk, but it was not statistically significant. One of the studies, now this was a retrospective data study. When we look at a prospective study, this prospective study was from GET. Now, which are these people? They looked at 199 older adults, 104 with diabetes, and 95 health controls. All of them underwent medical screening at the time, and they were followed up for more than a year or so. Balance, grip strength, cognitive status, mini mental health examination, and clock drawing test. They did their cognitive function, their frailty assessment, and what did they find was diabetes is a major risk for falling, even after controlling for poor balance, taking multiple medications, poor walking performance, and reduced cognitive functioning over a period of time with the duration of diabetes were mediators of the relationship between diabetes and falls. Longer duration and diabetes and taking a lot of diabetes medications, or multiple diabetes medications, one was the associated factors. Now, taking all this, what are the risk factors for falls? This is the risk factor assessment taken from the WHO by a study by D'Souza et al., the Asian Journal of Gerontology and Geriatrics. So the most common predictors. So we all know old age, all biological, environmental, behavioral, and socio-economic factors, including sex, race, age-related decline and strength, environmental factors, both extrinsic, intrinsic, biological, cognitive, so many factors are there. But which are the most common which may increase falls? The most common predictors of falls are abnormalities of gait and balance and the history of fall in the past year. If you look back at diabetes patients, majority of them who have neuropathy and a sensory deficit, they fall into this category. So it compounds a number of falls when you have diabetes associated peripheral neuropathy. So it's important that every diabetic, there is a risk assessment of peripheral neuropathy and a correction of the factors with appropriate footwear may decrease a lot of falls. Behavioral risk factors, including risky behaviors, socioeconomic risk factors include low income, low education, inadequate housing, and limited access to healthcare services. The extrinsic factors more likely to peak the cause for fall for the age group 60 to 74 years. Outside factors and intrinsic factors for more than 75 years or old. That means from 60 to 75, you should be very careful for extrinsic factors, environment. When you go out, you tend to fall more intrinsic factors which are responsible when you're more than 75 years old. So there's just a small distinction with these two. Now, diabetes medicines and their increased risk for falls and fall-related morbidity. This is a study from Elderly Health in a D group. And what they found was they looked at metformin, sulfonylureas, DPP-4 inhibitors, GLP-1 analog, insulin, and TZDs. We already know from one of the largest studies that people taking insulin are at increased risk, probably the duration of diabetes is more. There are multiple comorbidities. The increased fracture risk recently observed with TZD therapy is of great concern in the elderly patient. Please avoid TZD therapy in patients because it affects and deleterious effects on the bone health. We all know its deleterious effect on bone health and osteoporosis and the tendency to have more fractures. However, we also know that one of the other important factor from this is intensive glycemic control is a risk factor for falls. We saw Dr. Srivatsar telling us that what should be the guidelines as or the glycemic control goals. We should relax the glycemic control goals, not have intensive control or glycemic control as the patient ages, and hypoglycemia is also an increased risk of falls. This can be severe hypoglycemia. Patient having HAVs doesn't have, or hypoglycemic unawareness, and has a severe hypoglycemia, severe neuro, has a throws in a seizure, falls unconscious at somewhere, and there's an increased risk of fractures. Now, how do we prevent that? And to prevent it, we have this ACO indicators assessing care of vulnerable elders. So there are 12 factors. These are based on evidence-based focus on most 182 articles. And what they said is all vulnerable elders should have an annual documentation. That means anybody who's vulnerable, every diabetic is a vulnerable patient. If he's on insulin, if he's on having peripheral neuropathy, basically any elderly person, about the occurrence of recent falls. Falls are common, preventable, frequently unreported, often cause injury, can restrict activity unnecessarily. A recent fall, if somebody had one fall, believe me, they're going to fall again. Please assess the cause for the fall. And how do you assess the cause? We can use this ACOB indicator to assess and need some multi-factor. It is not one factor. There are multiple factors. Let's go. If you have this multifactorial risk fall assessment, if you do this, you will have 18% fewer falls and 37% of fewer of any falls within a fall risk assessment program. They assess this program. The idea this program is good is because the number of falls which you're going to do is less. So the fall risk assessment features medication review, orthostatic blood pressure measurement, vision assessment, gait and balance evaluation, cognitive evaluation, assessment of environmental factors, assessment of muscle strength. You need to take the circumstances, the medication, the chronic condition, mobility status, alcohol intake, psychotropic substance intake. You can use all the positive to tailor a fall prevention specific for each individual. The fall in everybody is different and there is a different cost. It is not the same. So we can't bear this alone. So if you have indicator 3, that means more than one fall because of orthostatic hypotension, please reassess every 3 months that it doesn't have orthostatic hypotension, and whatever the cause needs to be addressed. If there is documentation that there's a visual activity, problem with visual activity, one of the commonest things for a fall, they cannot assess where they're keeping. And you should do this again and again to make sure his visual and take care of his vision and reduce fall. And there is difficulty in ambulation. If you have more than 2 falls and the worsened difficulties with ambulation, balance, or mobility, then you should document, look at the gait, balance, and strength evaluation within 3 months of the report and do the necessary tests. And how do you do gait and balance? Time get up and go test is the simplest thing which you can do at the clinic. Patient walking into your clinic, sitting on the chair, going back itself will give you an assessment of the gait, and also some to some extent frailty, single leg stand test, dynamic gait index, Berg's balance. They're all questionnaires available. You can have a look at that and document them. Indicator, if you have more than 2 falls because of a cognitive assessment, memory loss or dementia, we saw this, you need to find out, you need to go into depth of this and look at this particular distance, because this is also an important part of the fall. And then if anybody has a vulnerable history of fall at home because of an extrinsic factor or because there is some sort of change which you want to make at home, steps, bathroom flooring, no hand railings for them to hold on, there are innumerable causes. We all know them, slippery floors. So why make that necessary changes? Bathroom, aids, non-step entrance, covered parking, this can go on and on. So some of the things where you need to make sure that you have this while getting up from this there are many things I'm not going to do. Unsafe bathrooms are one of the commonest things for fall. 9th indicator, use of medications, especially medications which work on the CNS, benzodiazepines. People take a lot of drugs, all the drugs which has some sort of effect on the CNS. Please ensure that they are not the one which is causing the imbalance or the cause for the fall, and tailor these medications appropriately so they do not cause a fall again. So review all medications. They are on polypharmacy, modify psychotropic medication and discontinue if appropriate, rationalize all drugs taken. And another thing is poor balance and proprioception, which I told you is very, very important. And assist devices, if you have more than 2 falls, if they are using any assist devices, please recheck them even with that if they are going to have a fall. Need to assess that also. Then there's another thing. This is called fear of falling, or you can call something like pre-frailty. So here, people with the fear of fall will have activity restriction and perceived poor health, reduced strength and poor balance, increased stability, reduced interdependence, and increased fall risk, poor quality of life. Off of those, and fear of falling may not always precipitate activity restriction. Half of those who report fear of falling do not restrict activities, but lack of social support, which is, I think, is the greatest thing in today's world. There's nobody, many people are living alone. I think it's a bigger challenge and another day for discussion. Depressive symptoms, multiple falls, and presence of more than 2 chronic conditions are associated with fear of induced activity restriction. So, in summary, one of the most important thing is extremely important. Try to prevent falls. If there is a fall, take him as an high risk individual for another fall. So, like a high risk food, high risk individual for another fall. Assess using the Anko score what is the reason for his fall, and based on it, please correct it. Whatever it could be, medication, cognition, orthostasis, vision, gait, balance, hypoglycemia. Encourage exercise to improve muscle strength and balance. Consider assist devices. They are assist devices and they're still falling. Reevaluate them. Use home safety assessments to improve their safety at home. Screen for fear of falling, counsel to improve mobility. The most important thing and not spoken most, appropriate footwear. Most of our elderly people walking in would not have using, they're not using appropriate footwear, which will help them to walk better, balance better, and prevent a fall. Thank you for your patient listening.
Thank you, Dr. Sanjay Reddy. I think you have put in a lot of information in such a short time, very relevant information. I would like to say at this stage, before we throw open for discussion, that why we chose this webinar. The reason is that all these 3 conditions, they are seen in the geriatric practice quite commonly, but the physicians in the community, they do not much understand about the implication of these and when they happen along with a disease like diabetes. That is first reason. The second reason is that over the years, increasingly new guidelines are being propounded about the glycemic goals for various kinds of such morbidities, particularly dementia and frailty. The third reason why we said that we should have this webinar, that all the 3 conditions are highly preventable if we take appropriate step at proper stages. And I think all the 3 esteemed speakers have given a lot of emphasis on prevention. That is the third reason. And just very few small comments about the falls and particularly fractures. There is a lot of information about the bone density in diabetes. And paradoxically, bone density in diabetes is actually increased, not decreased. In spite of increased bone density, they are more vulnerable to fractures. And the reason why it is said, the reason is that if you measure there what is called trabecular score, the architecture of the bone, that is weaker in them. That is one reason. And second reason, there are a lot of non-skeletal causes of falls in the diabetic. They have, for example, they may have diminished vision, they would be dementic, they may have also have hearing impairment, they are frail, and as Dr. Reddy says, they have polypharmacy. All these things are actually contributing to falls in diabetes, which is happening more than in non-diabetic elderly. That is about the falls. With regard to the frailty, I think I would like to share a very recent paper which I was going through by Dr. Sinclair from England. Dr. Sinclair is one of the pioneers who put down several years before the guidelines for treatment of elderly diabetics with glycemic goals and all that. Now he comes out and says, in opposition to what has been usually believed, that frailty people should not be getting weight losing anti-diabetic drugs because they are already frail. But what Dr. Sinclair says, he has now divided the frail patients into two categories, frail diabetic patients. One, he says, AM, that is anorexic, malnourished, thin. And second category, he says, SO, that is sarcopenic obese frailty. And he says that when they are sarcopenic obese frailty, they are overweight, but they are actually frail. Their muscle power is very less, muscle mass is very less. In those patients who are overweight, you can still use SGLT2 or this receptor agonist. You can still use it. But those which are the AM type, the anorexic malnourished type, you should not use this. So he has further dissected the indications of these drugs into frailty subclassification. And about the dementia, of course, Dr. Ambali has already very clearly emphasized the importance of different stages. So I think I think if the message goes that these are the preventable conditions, the physician has to be aware of these conditions, I think the job is well done. Thank you very much. And now it is open for floor. We still have about 11 minutes at our disposal. So I think anyone would like to comment. Anyone, please.
All of these conditions, although they are the most prevalent conditions, however, there is very less focus on these conditions, especially in our meetings. I think the healthcare provider needs to be sensitized first before we go in for primordial or primary prevention in these areas.
For this particular reason, when our interest group is going to meet in Bhubaneswar, one of the topics we have chosen for a flash talk is only a 5-minute talk by Dr. Ambali. He is going to discuss comprehensive geriatric assessment, which is an office procedure, and the whole intention of this assessment for an elderly individual is to find out many impairments, including these three impairments, what we have discussed today. Because once a physician develops a habit of assessing an elderly person in his clinic, then he knows where he stands. Is he in a pre-frail stage, or is a mild cognitive impairment to begin with, or he is liable to fall, or those who are already advanced. So he can take appropriate steps for handling such situations as they come to his clinic. So we are looking forward to that presentation. In addition, there are other flash talks also. So I think that is as far as my take is concerned. Dr. Jetwani, would you like to say anything?
I would like to ask all three speakers to give some take-home message to the physicians. For first, Dr. Anand, what will be the ideal clinical screening tests to identify individuals where you will subject them to further tests for dementia? What is the first thing that you will do in clinic so that you can identify this individual requires further assessment for dementia?
Yes, sir. So we practice recommended is 3-item recall test in a clinical scenario. While taking history itself, we do the 3-item recall test, and after completing our examination, we tell them to recall those 3 words or 3 items shown. And if all 3 are positive, fine, no need for cognition involvement. If only answer is 1 is right, and patient is having other symptoms also, we subject them for detailed evaluation for cognition like MOCA or MMSE or Edenbrooks. And we have to also find out the other reversible causes for forgetfulness or dementia like thyroid disorders, vitamin B12 deficiencies, especially in patients with metabolic backgrounds.
Dr. Anuba, from your point regarding frailty?
Yes, sir. I will definitely agree with Vinod, sir. How he's saying, like, we need to assess the frail patients. As Dr. Ambari was suggesting, all the patient, like some talk about or question him about exhaustion, fatigability, weight loss. Just simple test, timed up, getting up from the chair, walking around, and sitting back on the chair, a 4-meter walk test. This is a simple test which can assess frailty or a pre-frailty in an individual. Certain questionnaire to assess the clinical frailty score can be helpful in assessing and dividing them in where sarcopenic ones with the weight loss people are concerned. A rational medication can be decided or a right way of treatment can be chosen in these group of drugs where you can prevent falls also, and hence the well-being of the patient may be improved.
I think we welcome Dr. Bansi Sabu and Dr. Amit Gupta, who are the brain behind this interest groups from Diabetes India.
Welcome, sir.
Thank you. Thank you.
Good evening, sir.
Good evening, Dr.
Good evening, sir.
Well, I would say it is
Dr.
not only the
Sanjay
brain
can
behind,
give point.
it is the heart behind also.
Yes, yes. So Sanjay, what is the one thing that you will evaluate on the first visit in clinic that to identify individuals who are at risk of fall?
done a small thing. What we do first is patient walking into the clinic with support or without support. One, whether he's walking with an attender or not, if he's holding the attender or he's walking confidently and coming and sitting in the chair in front of you. First, the second thing which I want to look at is footwear. And third is his eyesight. These are simple things. All other things are something which I need to go back and check about his history and all of it. The thing where the most important and the best test I like is he coming and sitting in my chair and going back and opening the door. This will assess 4 things. 1, muscle strength. 2, coordination. 3, walking speed. 4th, vision. 5th, and most important is look at his footwear. Majority of the people who fall have come into the clinic within number of these 5 things is important. And once you have a fall, and if there is a history of fall, put a red mark
Yes.
onto the case sheet and say, okay, you are at increases. We looked at the data. It is so alarming that if you have a fall and a fracture and you're
Recurrent
hospitalized,
falls.
mortality is very high. So something like a red mark on the case sheet or to indicate that this individual has a fall. These are the 5 things which I look for when they come in. All other things are there in the case sheet to assess, and never miss to look for, especially for orthostatic hypotension. This is one of the most common, and the most common complaint which is there is, sir, I get up from bed, I feel dizzy.
Dizzy.
We document these simple. All of this are covered when you do. But just walking into the clinic, these are the things which we assess to make sure that this person is going to have a fall or not.
Dr. Bansi, would you like to say anything?
Sir, I just want to add few things which are very important clinically, which I always feel that now it's a time that we should learn, all the diabetologists and all the doctor and physician, there should be a classroom to clinic. We talk so much in classroom, but many of us, we don't follow in our clinic when we see the patients. I have seen the busy clinicians and diabetologists, they hardly bother for any other thing. They talk very nicely that we should not have a glucocentric approach. We should do all other things, and they don't do in their clinical practice. And similarly, we see those young doctors, very good, when they come to give the talk, they can talk on anything, but they don't do in their clinical practice, even though they have a time. And they don't want to listen other also. So I mean, this interest group, the complete idea is that whatever we are listening, whatever we are discussing, each one of us should try to follow all those things in our day-to-day clinical practice. Because in last 25 years, even we have done so much so, but still the average A1C could not be improved, and we could not do many more things for our diabetic patients. So this is the time that we should take a oath in Diabetes India that it's a time that whatever we are learning in classroom, in conference, we should apply in our clinic also. This is very important because this is the journey of my 25 years in field of diabetes, and I am seeing the prescriptions of all those seniors and all those juniors, which I can call them, but still not able to find the best of the best treatment. Otherwise, I mean, the sarcopenia and the frailty, these are very important topics which we are just neglecting, particularly for the elderly people, and we find them, I mean, by diabetologist, how many of you are really writing the prescription for osteoporosis? How many of us are sending the patients for physiotherapy, asking them for all those regular checkups, postural hypertension, the blood pressure monitoring? Even after a newcomer who comes to my clinic as a post-MD, we ask them, have you checked the blood pressure of the patients after asking him to stand? They have not done in their clinical practice of last 4 years, not a single time. And this is the MD who has passed MD medicine, and this is the scenario. So, I mean, I'm not criticizing here anyone, but this is just to tell that we should do more and more such activities just to improve the care for our diabetic patients. Thank you, sir.
But I would also like to say that these messages, they have to pass from a clinic to the patient home. Of course, that is very important. But the second thing I would like to raise here, that the interest groups that have been created, and they are discussing with each other many things which normally people don't discuss. We are able to go into the depth of very practical issues, and more knowledge is coming, not only from the point of view of medical knowledge, but even wisdom is coming. And this wisdom, I think one has to distinguish the knowledge from wisdom, and the wisdom has to pass. Wisdom has to pass to the patient, because
at least I can say that I am becoming more wiser, and probably my practice will definitely improve. I am learning a lot by all these interest group, and I am the part of all the interest group, and I am very much regular reading. I know that the Pratap is very serious student from Gujarat, and same with Akash, because I know about the Akash that in midnight he read every day. But many of us are reading, some newer data and something, but some minor things we are really missing in our day-to-day clinical practice. So this interest group will definitely improve our knowledge, and we will able to use this knowledge in our clinical practice. That's very important. From classroom to clinic, it should come.
Agree with you, Bansi.
Anyone else?
Totally agree with you.
Yes. Anybody, Dr. Akash, you want to say anything? The chairperson of the webinar today?
I think in this Diabetes India group meeting, we should come up with a project to screen the patients. We can involve a lot of other healthcare providers for dementia, frailty, and falls. So we should make a comprehensive. I will come up with a study plan to study all these aspects in the clinic setting, so that we can at least have a large study where we can study all these aspects.
There is a proposal to prepare a position paper on many of these aspects. And
we just study the prevalence presently, and then we can go about the next other things.
Okay.
Akash, we have already done that retrospective data analysis, and we are planning to do one prospective data analysis with focus on this particular attention on this geriatric syndromes, that polypharmacy, frailty, falls, urinary incontinence, dementia. So we will do something regarding that, and next year, probably from February or March onwards, we will do prospective study to identify these parameters.
Are we going to present this? Are we going to project this, I mean, as a project in this Diabetes India from this group?
Yes. So we have already done one retrospective analysis, and now we are planning to do one prospective.
Great.
So I think we are right on dot. It's 8:15. If can we request Dr. Jetwani to please give the vote of thanks.
Yes, sir. Ankit, are there any questions from the audience or participants? Ankit, are there any questions?
Yes, please go ahead.
So what could be the mechanism of insulin therapy predisposing an elderly to dementia by Dr. Ripul? So Dr. Anand.
Yes, sir. Insulin is known to produce, especially its effects on brain as an insulin hypersensitivity or insulin resistance that takes place. So it happens when hyperinsulinemia or insulin resistance when appears in the CNS, it leads to accumulation of amyloid plaques. That is the one proposal hypothesis. And second one is insulin leading to hypoglycemia. That affects again the brain tissue damage, and multiple episodes of hypoglycemia is another risk factor for developing dementia. So these are the two issues how the insulin takes up, leading to dementia in the older people.
Second
Another
question.
is, sir, can we give Biomet and DPP-4 in diabetes? But how to treat forgetfulness?
Yes, forgetfulness is a symptom, and we need to evaluate what exactly it is. It's just an forgetful of aging, or it is an minimal cognitive inhibition, minimal cognitive cognition, or there is an dementia. So in this aspect, again, if we get minimal cognition, there impairment is there, then again we can prevent it going for the dementia. We have to look for reversible causes of dementia, in especially in the setting of diabetes mellitus, because one of the metabolic syndrome, again hypothyroidism, vitamin B12 deficiency, and old stroke, old vascular events can all lead to dementia. So the question starts is how to treat forgetfulness. Yes, it depends upon what is the cause, and there is no clear cut like forgetfulness is there. We have to counsel him, and is it the first counseling of forgetfulness aging? If not, go for next minimal cognition impairment. Then we have to evaluate him, and then if it is again it's in reversible or irreversible, then irreversible cause, go ahead for again further evaluation for full-fledged dementia, maybe it's Alzheimer's or frontotemporal or vascular, like that. Or if it is reversible, treat the patient with reversible conditions, especially the correction of hypothyroidism and vitamin B12 deficiencies. Frequent history of alcohol intake is there, and smoking, it has to be stopped, because that also has an irreversible causes for dementia in older people. So again, it depends upon what is the cause for the dementia, and then we have to treat it accordingly.
Well, I think there is a comment I would like to say. Well, of course, a very short answer is that if there is a full-fledged forgetfulness, there is no drug which can treat forgetfulness.
Yes.
But it can certainly be prevented. And
Yes.
if some forgetfulness has happened, its progression can be prevented, it can be retarded.
Yes,
and
sir.
there are two things, apart from what Dr. Ambali has said, there are two things I would like to say. I think there is a role of what is called cognitive challenging. All the elderly people or the people who are going to be elderly, about say 55 or 60, who are going to be retired after some time, they should continue to challenge their brain by all kinds of brain stimulating activities. I don't want to go into the detail of these activities, but that is number one. Number two, a very important thing, that one has to be socially very interactive. If people are extrovert, meeting friends and relatives, attending events, and we are of course attending so many conferences, that is also one of the good things. So social connectiveness and cognitive challenging is a very important aspect for preventing an elderly person to get forgetful or even dementia. That is what my take is.
Thank you, sir.
Amit, would you like to make any comment?
Thank you, sir. I would just like to say that it was a fantastic webinar, and the theme of triple 3F is really very. We learned a lot of things, as rightly pointed out by Vinod Kumar sir as well as Bansi sir, that we need to take these things into our clinical practice, and this is exactly what was the idea behind creating these interest group, was that we can have more deep discussions, more discussions on topic which are usually just touched in many of the meetings, or are not the part of the routine discussion. So I think we are on the right track, and we learned a lot. And with this webinar, I think all of us have become more wise, and we
Wiser.
would try to wiser, and we would try to use these uh, pulse of clinical practice which we have picked up from this discussion. We will try to incorporate them in our clinical practice. So once again, Vinod Kumar sir, this group is really rocking, and this group is really doing a lot of good activities and at the top of the chart, and is very close to me. And I really appreciate all the work you do. Thank you, sir.
I don't know how many
Thank you.
people have attended this, but if recording has already been done, Amit, is it possible to
Yes, sir.
disseminate this recording to a large
Yes, sir.
audience?
We will,
Yes, sir.
sir. We will get the recording and we will send it to all the audiences,
Good,
and
good.
we can circulate it to all the groups.
So I think
Thank you, Amit.
Dr. Jetwani, the floor is yours now.
Yes. Thank you, Dr. Amit. First of all, let me thank Dr. Bansi and Dr. Amit for sparing their time and joining for this webinar. And Dr. Vinod Kumar sir for guiding and leading
Yes.
from the front and creating this concept of 3F, that is forgetfulness, frailty, and falls in elderly diabetics. I think we all know about medicine, but we forget. We generally keep on intensifying therapies, even in elderly people. But these
Yeah.
are the three important issues: frailty, forgetfulness, and falls. If they are there in your elderly people, then you have to de-intensify therapy rather than intensifying
Intensify.
therapy. You have to de-intensify therapy, and you have to give them whatever glycemic control is there, but better quality of life, because that is the important parameter in elderly diabetics. I thank Dr. Akash Singh for moderating the session, Dr. Anand for an excellent lecture on forgetfulness, Dr. Anuba on frailty, and Dr. Sanjay for getting us through the falls, not only in diabetics, but even in elderly. How can we prevent falls even if they are not diabetic? So I think with that, we end our seminar, and probably in next 2 months' time, we will again come with our third webinar. And I will request Dr. Vinod Kumar to think of the title of that webinar. It should also be catchy like this: 3Fs, because this is what is required in a routine clinical practice for a physician to understand the importance of these conditions, which we generally miss in routine clinical practice. Thank you, everyone, for joining.
Okay.
Good night.
Thank you. Thank you.
Thank you. Thank you.
And I also
Thank you.
thank RX Events, Nirav, Ankit, Neelam, and
Thanks.
Hardik for providing that technical support for this webinar.
Thank you so much, sir.
Thank you
Thank
very
you.
much.
Thank you, sir.
Thank you.
Thank
Good
you.
night,
Thank you.
everyone.
Thank you,
Thanks.
sir.
Good
Thank
night.
you.
Good
Good
night,
night,
sir.
sir.
Bye.
Good night, sir.
Good night. Good night.